Welcome, medicos. Let's begin with this quote: Master self discipline, and you will have the strongest weapon. Let's begin with today's topic. The topic is amoebic liver abscess. So, in this particular topic, we'll be discussing about the etiopathogenesis, the clinical manifestation, laboratory diagnosis, the treatment aspect, and the prevention of this disease. So, now we'll discuss about the pathogen. So, the most important cause of this amoebic liver abscess is Entamoeba histolytica. So Entamoeba histolytica is a parasite, it is a protozoan, and as an extraintestinal manifestation, it causes the amoebic liver abscess. So this is an extraintestinal manifestation. Liver is the most common affected extraintestinal site, followed by lungs, brain, genitourinary tract, and spleen. So this is an space occupying lesion of the liver, and the most important question here is the commonest site of the abscess formation. It is posterior superior surface of the right lobe. So this comes as an MCQ, that the most common site for this abscess formation is posterior superior surface of the right lobe. Now let us talk about the pathogenesis of amoebic liver abscess. So approximately 2 to 8% of the patient who have the history of intestinal amoebiasis gets this extraintestinal amoebiasis. So they develop this. So only 2 to 8%. And the transmission is through ingestion of contaminated food and water. And the food and water is contaminated by the cysts of Entamoeba histolytica. Now let us read about the pathogenesis with the help of this flowchart. So after ingestion of the cyst develops into trophozoites. And then after that, they adhere to the intestinal mucosa by virtue of gal-lag-lectin antigen. And this antigen is the major virulence factor of Entamoeba histolytica. And mark this because this is a very important MCQ question also. And after attachment, these trophozoites secrete cysteine proteases and hydrolytic enzymes. With the help of these cysteine proteases and hydrolytic enzymes, they invade the intestinal mucosa. So invasion of intestinal mucosa happens. And in few cases, erosion and necrosis of small intestine is so extensive that these Entamoeba histolytica, the trophozoites, gain entry into the portal venous system and they are carried to extraintestinal sites. So they get carried and reach the extraintestinal sites. And we have a very crucial property of this Entamoeba histolytica. They have a crucial property and they have something which is very critical for survival in the bloodstream. So for that, they have resistant to complement mediated lysis, which is provided by this gal-lag-lectin antigen only. So they are resistant to the complement mediated lysis, hence they survive in the bloodstream. After that, they reaches the liver. Once these amoebic trophozoite reaches liver, they occlude the hepatic venules and this leads to anoxic necrosis of the hepatocytes. And after that, due to the inflammatory responses around this hepatocyte, it causes formation of abscess. And the neutrophils which were recruited, these neutrophils are lysed by the amoeba, and these amoeba lyse these neutrophils and the mediators are released, and these mediators contribute to the hepatic necrosis. Now let us see the microscopy of the abscess wall. So this abscess wall will be talking about inner central zone, the middle zone and the outer zone. So the inner central zone, it has the necrotic hepatocytes without the amoebae. The middle zone of degenerative hepatocytes, RBCs and few leukocytes, and occasionally they have amoebic trophozoites. So this middle zone comprises of this, and the outer zone comprises of healthy hepatocytes which are invaded by amoebic trophozoites. This liver abscess pus is given a typical name, important name, anchovy sauce pus, due to its characteristics appearance. So this liver abscess pus is thick in consistency, it's chocolate brown in color, and the fluid is acidic with pH 5.2 and 6.7. and it consists of the necrotic hepatocytes without any pus cells, and occasionally amoebic trophocytes are also seen. And these amoebic trophocytes are mainly seen in the last few drops of the pus because the amoeba multiply in the wall of the abscess. So that is why in the central part we will not see, but in the last few drops we will be able to see this trophocytes. And remember this Anchovy-sauce pus. This is seen in amoebic liver abscess. This is a typical MCQ of this topic. Now let us see the clinical manifestation. So generally the patient will present with tender hepatomegaly, then and fever, which are the most consistent feature of this amoebic liver abscess. It may be associated with weight loss, sweating and weakness, and very rarely they will present with jaundice and cough. So here what we have to remember, tender hepatomegaly and fever. So tender hepatomegaly and fever will be the most consistent feature of amoebic liver abscess. Now let us read about the complication of amoebic liver abscess. So generally this complication arises due to discharge of the contents. So whenever the liver abscess will rupture and the contents will be discharged into the neighboring organs, at that time it will lead to complication. For example, the right-sided liver abscess may rupture externally to skin, and when this is ruptured and the contents is discharged, it causes skin lesion of the abdominal wall, which is known as granuloma cutis, that is amoebiasis cutis. Or it may rupture into the lungs, causing pulmonary amoebiasis with trophozoites in sputum. So we'll be seeing trophozoites in the sputum. Or if it ruptures into the right pleura, it will cause amoebic pleuritis, and this is the most common complication. So the most common complication being rupture of the right-sided liver abscess into the right pleura, causing amoebic pleuritis. Now when the liver abscess rupture below the diaphragm, it causes subphrenic abscess and generalized peritonitis. So there will be generalized peritonitis. And now let us see what happens when the left-sided liver abscess rupture. So the left-sided liver abscess may rupture into the stomach or the left pleura or to the pericardial cavity. And when it ruptures into the pericardial cavity, it will cause amoebic pericarditis. Hematogenous spread can also occur from liver, affecting the brain. If it affects the brain, it will cause brain abscess or secondary amoebic encephalitis. It can affect the lungs, spleen, and it will cause abscess. It can affect the genitourinary organs, causing painful genital ulcers. Now let us talk about the most important aspect of microbiology, the laboratory diagnosis. So in this we can use microscopy. In this we will be detecting trophozoites and never cyst. We can detect only trophozoite, and it is less sensitive, 25%. Then antigen detection we can do in the serum, in liver pus and in the saliva by ELISA. And antibody detection. Antibody detection in serum is much more useful in case of extraintestinal amoebiasis than in intestinal amoebiasis. So here we use the ELISA. Molecular diagnosis, we can use nested multiplex PCR and real-time PCR. Then we have ultrasonography. So in this we will be detecting the site of the abscess and its extension. So microscopy, antigen and antibody detection, molecular diagnosis and ultrasonography. Now let us talk about the treatment of amoebic liver abscess. So we have tissue amoebicidal agent, and this act on the trophozoites which are present in the liver. Followed by this, luminal amoebicidal agent will be used to eradicate the intestinal carriage. Luminal means lumen, the anti-amoeba stereolytica which is present in the lumen. To eradicate those, luminal amoebicidal agent will be used. So let us see what are the tissue agents. So for tissue agent we have metronidazole. So metronidazole 750 milligram per oral, that is orally. So 750 milligram orally metronidazole can be given for 5 to 10 days, or IV 3 times a day for 5 to 10 days can also be given metronidazole. Or we can give 2 gram orally once, tinidazole or ornidazole. In luminal agents we have idoquinol, which we give for 20 days, or we can give paromomycin for 10 days. Then since the abscess is formed, so if these situation is there, then aspiration of the liver abscess is indicated. For example, if there is a risk of impending rupture, or the left lobe of liver abscess is greater than 10 centimeter, or there is no improvement even after the anti-protozoan therapy for 5 to 7 days, then aspiration is indicated. So for prevention, we should know what is the mode of infection. So the mode of infection was ingestion of food and water contaminated with the cyst. So for prevention, we should avoid any food or water which has high probability of being contaminated with human feces. And then treatment of asymptomatic person should be given. We'll get back to you soon. Let's end with this quote. You can if you think you can. So believe in yourself and go ahead. Thank you.